On behalf of the Chronic Liver Disease Foundation, I'd like to thank you for joining today's webinar, which is entitled Looking into the Crystal Ball, Predicting the Future Challenges of Fibrotic NASH, and featuring Dr. Mazen Noureddin. Good day, I am your host, Jerry Mayberry of Echosens North America. Today's webinar is funded by Echosens North America, the inventors, manufacturers, and distributors of the FibroScan technology. This presentation includes information on the uses of the FibroScan technology from published literature. Echosens does not intend to make any specific claims found in this presentation. The FibroScan is FDA cleared as an aid to the diagnosis and monitoring of patients with chronic liver disease as a part of overall assessment of the liver. It is not intended for the treatment of any specific liver disease or condition. Before I introduce Dr. Noureddin, please be aware that all participants are muted to sustain sound quality. If you have a question during the presentation, please type it into the questions panel displayed on your computer screen. When we reach the question and answer time period, the aggregated questions will be read for Dr. Noureddin for his response. We apologize in advance if we do not have time to answer all submitted questions. Now I wish to introduce today's speaker, Dr. Mazen Noureddin, the Fatty Liver Program Director at Cedars-Sinai Center in Los Angeles. Dr. Noureddin.
Thank you, Jerry, for the introduction. This is Mazen Noureddin. I'm the Director of Fatty Liver Program at Cedars-Sinai Medical Center in Los Angeles. So I was given the task today to talk about non-invasive testing in non-alcoholic fatty liver disease. I was also given the task about talking about future challenges in fibrotic NASH treatments, which some of it is going to be prediction, so we'll go through this prediction today. So the objective of this talk today is, one, to talk about the epidemiology, and this one is going to be brief. I will refer you to Dr. Younos's webinar earlier in the series, which was excellent talk. I will also talk about high-risk patients. It's very important to define who needs a treatment and who doesn't need it based on non-invasive testing. Most importantly, I'm going to talk about the update on non-invasive testing and what's out there and what's the most recent literature. And finally, I'm going to end this talk with future challenges and solutions, especially we have possible new medications coming on the horizon. This is a study done by Dr. Younos. This is a meta-analysis looking at the global prevalence of non-alcoholic fatty liver disease, which is estimated to be 25%. In the United States, it's estimated to be 24%, and in South America and the Middle East, it's higher, 31-32%. And it varies around the world based on their risk factors and metabolic profile. In this slide, this is a study we published in Hepatology in 2016 from a large cohort in California and Hawaii. This cohort is called the multi-ethnic cohort, and on the top, you see here non-alcoholic fatty liver disease in purple as the most common cause of chronic liver disease. This is known from before. However, what we show you in this paper, that non-alcoholic fatty liver disease in purple collectively is the most common cause of cirrhosis. This varied by the ethnicity. So Latinos, it was the most common cause of their cirrhosis, same as for Japanese Americans, Native Hawaiians. In African Americans, it was the second leading cause for their cirrhosis, and in white, it was the second lead of their cirrhosis after alcohol. This is a study we also published from the UNIS data, looking at NASH as indication of liver transplantation. In the left, NASH was the second leading cause of liver transplantation in male, as shown in red. In the blue, alcohol is the leading cause for transplantation in male. In contrast, in females on the right, we show for the first time that the leading cause for liver transplant in females is non-alcoholic steatohepatitis. The second leading cause for them was alcoholic liver disease, and this slide shows nicely how hepatitis C became the third leading cause of liver transplantation, and I'm sure it's less by now, given the antiviral therapies introduced in 2013 and 14. So as many of you or all of you know on this webinar, that non-alcoholic fatty liver disease is a spectrum. It starts with NAFLD, which is very much simple steatosis, and the majority of patients fall into this category. It progressed to non-alcoholic steatohepatitis, and what you need here, inflammation and cell injury on top of the steatosis. And this form is the one likely to progress to fibrosis and cirrhosis and possibly hepatocellular carcinoma. In the box, I show you the NAFLD activity score developed by the NASH CRN, which is used in NASH clinical trials to meet the criteria for entry. So the NASH score is being used as 4 and above quantitative measurement to enter into clinical trials. The natural history of non-alcoholic fatty liver disease and NASH is still being investigated. There are multiple studies that have been done, and what we know so far that it takes about 7 years for development of one stage of fibrosis. So on average, it takes about 20 to 40 years to develop cirrhosis. However, there's a subgroup that develops cirrhosis much faster. We call them the rapid progressors. Also, as you know, NASH patients, and especially cirrhotic patients, are at risk of developing hepatocellular carcinoma. Patients at risk of NASH, we found that people with metabolic syndromes are at the higher risk of developing NASH. And since then, there have been a lot of efforts to look into patients at risk of mortalities. And here, this is the Angola studies in gastroenterology 2015 that showed fibrosis is actually the prognostic factor that predict liver outcomes in non-alcoholic fatty liver disease patients. So here it shows you the hazard ratios of outcomes and mortality as well as liver transplantation. And as you see here, starting in the F2 and higher, patients have a worse outcome. In another study done in Europe, about 6,000 patients were enrolled in this study, and it had a 20 years follow-up. On the right, you see the fibrosis in predicting the severity of liver disease. And as you see, when you get to the F4, which is cirrhosis, you're at higher risk of decompensation. On the left, similar to the previous studies, starting from F2, it shows you you're at higher risk of having mortality, especially when you get to F3 and F4. And there are other studies and the poor analysis supporting these studies, and because of these studies, the current NASH clinical trials enroll patients with steatohepatitis and F2 and above. So those are the studies that have found the foundations of F2 and above to be enrolled in phase 3 studies. And this component of fibrosis is very important because the non-invasive test can detect fibrosis accurately. And there are many tests, and here I list the most important tests and the most accurate ones. So you do have serological markers. You have simple ones, such as FIB4, NAFLD fibrosis score. You do have complex ones, such as FibroSpect, ELF, ProC3. You also have imaging that use elastography-based techniques, such as the VCTE, MRE, and RFE. And today's talk will focus on those and what's the update and what we're doing in this field. The FIB4 score is endorsed by the American Association of Liver Disease to be used to stage NAFLD patients, especially those at risk of advanced fibrosis. So the FIB4 contain age, AST, platelet, and ALT. And it gives you three kind of results. If the FIB4 is low, it means no advanced fibrosis. If the FIB4 is high, it tells you that this is advanced fibrosis, and there is an area of indeterminate results. Similarly, NAFLD fibrosis score is another test endorsed by the American Association of Liver Disease to be used to stage patients with non-alcoholic liver disease that are at risk of advanced fibrosis. This test includes age, BMI, impaired glucose, AST-ALT ratio, platelet count, and albumin. And also similar to FIB4, it has three kind of results: advanced fibrosis, no advanced fibrosis, and indeterminate. So, as I mentioned, these two tests are recommended by the guidelines for staging patients at risk. Moving on, there are new non-invasive testings looking at advanced fibrosis. This is a new study looking at the Fibrotic NASH, distinguishing F3, F4 from F0, F2. And the Fibrotic NASH include alpha-2 macroglobulin, hyaluronic acid, and TIMP1. And in this study, they had multiple validation cohorts, and the area under the curve was 0.85 in one of the cohorts, 0.86, and 0.86 in the combination cohort. And this Fibrotic NASH performed better than the FIB4, which had area under the curve of 0.77, and better than NAFLD fibrosis score, which had area under the curve of 0.61 in this study. Very important two tests in the next two slides: the ELF score and PRO-C3, which has a lot of promising potential. So this is a study that has been done in NAFLD patients to predict fibrosis, and the ELF score contains hyaluronic acid, procollagen 3 amino terminal peptide, and TIMP1. And the ELF is in blue, correlated with fibrosis, and importantly, the area under the curve was 0.90 for severe fibrosis. Severe fibrosis was defined in this study as F3 and F4. For moderate fibrosis, it was 0.82, and moderate fibrosis was defined as F2 and above. For no fibrosis, the area under the curve was 0.76. So the area under the curve for this test for severe fibrosis was excellent. 3 is one of these new promising tests, and this is a new study that was published in Hepatology this year. PRO-C3 is a marker of type 3 collagen formation. In this Australian study, they had two cohorts: derivative cohort of 150 patients and a validation cohort of 281 patients. And what they did, in addition to measuring PRO-C3 in the blood, they developed an algorithm that contained age, presence of diabetes, and platelet count. They called it the ADAPT score. And what the ADAPT score did, it performed very well in predicting advanced fibrosis, and the area under the curves was 0.86, which was higher than the other non-invasive testing, such as FIB4, APRI, NAFLD fibrosis score. Moving on to the imaging-based non-invasive testing, which overall have shown to be more accurate than the serum testings. And here I show you the Transient Elastography, or vibration-controlled Transient Elastography, which I will refer to the rest of the talk as the FibroScan. It does two things. It measures liver stiffness, and the unit here is kPa, and it measures also the steatosis and quantify them, and the measurement of steatosis is done via the CAP probe, controlled attenuated parameter, and the units are listed here. This slide shows the Transient Elastography screen, and here you see the blue number, which is the number for steatosis. This is a normal number, and the orange number is the number for stiffness, and this actually is a representation of the fibrosis. Many of you know this, but for those who don't know, those numbers are completely normal. The orange number, the stiffness, is KPA, and I usually point out this to my patients, and I told them the orange number is what matters. And here, the nice thing about it is it gives quantification of both steatosis as well as fibrosis on the spot for the patients. There's a recent study that I think was very well performed, looking at the cutoff for both the CAP score as well as the fibrosis score or stiffness score in FibroScan. And the nice thing about this study that it was a large cohort in 383 patients, and the patients had bare biopsy and FibroScan done within 2 weeks of each other. So starting with CAP, they defined multiple cutoff, and they start with sensitivity threshold analysis. So for S1, S2, S3, it was 274, 290, and 302, and the sensitivity was excellent, 0.9, 0.9, 0.9, and those are the numbers that I use in my clinic today. They also did the Noureddin index for the CAP score for S1, S2, and S3, and the numbers here was 302, 331, 337, with a very good area under the curve, 0.87, 0.7, 0.70. Moving on to the stiffness or fibrosis, the sensitivity analysis, there was lower cutoff values, and that's shown here, and the sensitivity outcome was excellent of 0.9, 0.9, 0.91. The Noureddin index was very good as well. For F2 was 8.2, for F3 was 9.7, and for F4 was 13.6, almost 14. And those are the numbers that we have been using for some time now. The area under the curve for F4 was very good, 0.89, for F3 was 0.82, for F2 was 0.77. And here we nicely can use multiple cutoffs for F2 and F3 and F4 in contrast to the blood-based testing that use it for advanced fibrosis versus no advanced fibrosis. Moving on, MR elastography is another technique that also based on the stiffness technique and elastography techniques, and this is an example of what elastography looks like. On the top, you see two patients. On the top, you see a patient that has no fibrosis, and on the bottom, you see a patient with fibrotic liver disease. And to the far right, you see on the top patient that's color coordinated that has no fibrosis, and the color changes when you get fibrotic liver disease, and this is the change in KPA in these patients. The important concept here, similar to the CAP and the KPA in FibroScan, MRI also can be coupled with another software called MRI protein density fat fraction that many of you know as of today. And this is an example of 3 patients. The fat fraction is different in them, and actually this is a very important test because it's one of the main outcome in phase 2 studies in NAFLD patients nowadays. There have been multiple studies that compared MR elastography to FibroScan, including comparing the stiffness as well as the steatosis. In general, MR elastography has been shown to be more accurate, and this is a pooled analysis showing that. However, FibroScan performed well too. So again, MR elastography is more accurate, however, it's more expensive and less available. FibroScan is still accurate, and it's a point-of-care test. Now, moving beyond these accurate, important tests, and similar to the biopsy that I showed you earlier, that it predicts outcomes and survival, the non-invasive testing started showing that it predicts survival. Here is an example of multiple studies showing that the non-invasive testing predicts survival. Before, an alpha fibrosis score shown here predicted survival in these studies, and on the right, transient elastography FibroScan showed that as well. Very important, so we can move away from the biopsy, hopefully one of these days. Similar to the other non-invasive testing, ELF also showed that it predicts progression to cirrhosis and clinical events. This is a study that shown as in the form of abstract a couple of years ago, and on the left, ELF here predicted the progression of cirrhosis, and this is the baseline ELF, and if it was more than 9.76, it predicts the progression to cirrhosis, and the odds ratio came out as positive in the meta-analysis for ELF. On the right, this is also showing that the ELF more than 11.27, predicting progression to liver-related events. Again, this is the baseline ELF. So here we're showing you that the non-invasive testing started predicting outcomes similar to the biopsy. This is a study that we just presented in the EASL meeting in 2019. It's a large cohort from Texas and California that patients had MR elastography. And we find the cutoff for liver cirrhosis and the MR elastography to be 4 kPa. This has been shown in different studies. However, what has been shown here in a large cohort of multi-center non-alcoholic fatty liver disease patients, that a cutoff of 6.48 kPa predicted or correlated with decompensated cirrhosis. And these events included ascites, hepatic encephalopathy, esophageal bleeding, and even mortality, and we had good accuracy. This study just came out, and this is a really important study as it started looking at things longitudinally, and here they used multiple non-invasive testing. So first, they started cross-sectionally, and they used multiple non-invasive testings, and what they found that FIB4 and NAFLD fibrosis score performed the best, and they had cross-sectionally the best C statistics. FIB4 was 0.8 and NAFLD fibrosis score was 0.78. And then they did the longitudinal analysis. They had 216 patients that they had no advanced fibrosis at baseline, and 35 patients that progressed to advanced fibrosis after a median follow-up of 2.6 years. And then what they noticed here, a unit change of APRI had correlated with 0.33 change of fibrosis in histology. A unit change of FIB4 correlated with 0.26 change of fibrosis in histology, and a unit change of NAFLD fibrosis score correlated with 0.9 change on the histology of fibrosis. The area under the curve of APRI progression was 0.82, for FIB4 was 0.81, and for NAFLD fibrosis score it was 0.80. Again, this is a very important study because it shows that non-invasive testing can predict fibrosis progression longitudinally with very good accuracy. Now I have showed you that the non-invasive testing are very accurate. I have showed you that the non-invasive testing now can predict mortality. And there are studies that already started looking at things longitudinally. We also know that there are treatments coming in the pipeline, some of which might be approved in the very near future. However, there might be gaps that we might face very soon. And in the next few slides, we're going to start talking about some of these gaps so we can be ready for these gaps when they come, and we can have solutions for them. For instance, recommend liver biopsy to diagnose NASH prior to starting treatment. And the treatment recommendations now are vitamin E or pioglitazone based on diabetes status. However, many of you ask, What do we do next after we do biopsy and diagnose NASH? What do we look for? Is it ALT? Is it something else? Or do we need to repeat a liver biopsy? And even if I repeat a liver biopsy, what do we do after that? Do I keep repeating liver biopsies, and for how long? That is going to be hard. And as you know, many patients, when you talk to them about the initial liver biopsies, they're not very happy about it. And all patients in the horizon, they're now currently in phase 3, they're ongoing, or they entered phase 3. So elafibranor is in phase 3, obeticholic acid, which is a FXR agonist, in phase 3, CVC is ongoing in phase 3, Aramcol just entered phase 3, and the MGL3196 has also entered in phase 3. And many that was just presented by Professor Younasi in EASL 2019, and this is interim analysis of a randomized controlled trial of 18 months of obeticholic acid versus placebo in NASH patients. And the trial hit its primary endpoints in terms of fibrosis improvement by one stage without NASH worsening. So 23% of patients met the primary criteria of fibrosis improvement by 1 point compared to the placebo of 11.9%. The NASH resolution, which is the other criteria, did not meet the primary endpoint. However, you only need one of them to get FDA approval, and they met that. And as we talked about earlier, fibrosis is a very important endpoint because it correlates with mortality. So it's expected that in the future, this medication will get approval. And now we have to be ready for treatments that they're going to come in the pipeline. And this is likely to be the first one. So treatments are coming, and they're coming very soon. It's expected that other treatments are going to be approved in the near future. I showed you that there are few in the phase 3. There are others in phase 2, including combination therapy that they're being now tested. Non-invasive testings also have made good progress. So now we have to think and put things together and see what we're going to do. And we have to expect the challenges. So here are some of the future challenges that we might face in the very near future. For instance, we know that there are so many NASH with advanced fibrosis that they are not diagnosed. Also, the topic about liver biopsy is very important. Do we need it to start treatment? Do we need it to monitor treatment? And then, non-invasive testing. Which one we can use to monitor response? Or can we use them to start treatment? And then, once we start treatment, what do we need to use to modify treatment, to stop it, to switch it to something else? And finally, as you know, there are many medications on the horizon. And at one point, we'll have multiple drugs that we need to make a decision to start with one or two and decide which one we're going to use. So I'm going to go through some of these challenges using some data, but there will be some prediction what will happen in the future. So the problem number one, there's so many fibrotic NASH patients that they are largely underdiagnosed. And part of the problems comes from these issues. So the screening is not universally recommended. We do have issues with the most common used test now, which is ultrasound and ALT. And there's also an issue with access to the most accurate non-invasive testing. In terms of the screening, the EASL guidelines recommend screening patients at high risk, such as the diabetic metabolic syndrome patients with ultrasound and ALT. However, the American Association of Liver Disease do not recommend screening patients at high risk yet because of the lack of cost-effective analysis studies. So we'll likely, in the future, will have cost-effective analysis and these guidelines will change. But until then, screening is not recommended in the US. And are the numbers. So we will have more numbers while screening is not being done. So for instance, in 2015, the F3, F4 patients, there are 3.3 million people. In 2030, we'll have 7.9 million people. In terms of compensated cirrhosis, we have 1.2 million people. We'll have 3.1 million people in 2030. The death will increase from NAFLD, so as total death from NAFLD will increase. The ultrasound ALT issues are old issues that we're all aware of. For instance, previous studies have shown that the cutoff for ALT is 19 in female and 30 in males. And there are multiple studies show that the primary care physician only become alert when the ALT is elevated. Indeed, one study in the VA showed the primary care physician become alert when the ALT is upper limit of normal, and they usually use the laboratory upper limit of normal in their institution. But we also know that some normal ALTs are abnormal. So for instance, the study was done by Dr. Sanyal's group 16 years ago. And I want you to look at the bottom of the graph when the ALT is less than 30. And as you see here, many patients had significant fibrosis even when their ALT was on the low side. So ALT might not be the most reliable test to screen or monitor. Also, you're all well aware that the ultrasound is sensitive when steatosis is 30% and more. However, it can miss liver steatosis less than that, especially when it's less than 20%. In addition, ultrasound cannot predict fibrosis or assess fibrosis. Another problem why we will not be able to identify many of these patients, or we're currently not able to identify, is the access to the accurate non-invasive testing, and in particular, the FibroScan elastography. In addition, the cost-effectiveness studies are not done yet and need to be done. And in the meantime, I think the primary care physician should focus on the two endorsed tests by the American Association liver disease, which are FIB-4 and NAFLD fibrosis score. So in perfect world, once we have cost-effective analysis, we are proposing a solution. Again, this is a futuristic kind of look. So we believe that patients with type 2 diabetes or metabolic syndrome, maybe cutoff age will be added in the future, should be screened for NAFLD using ALT and ultrasound. And then if they do have non-alcoholic fatty liver disease, then staging should be done. So in a primary care setting, NAFLD fibrosis score and FIB-4 both should be used. Going to the green, if both are low, these patients do not need to be referred. Diet and exercise and lifestyle modification should be recommended, and these tests can be recommended and repeated every 2 to 3 years. On the right side, this is the red side, or if both tests are elevated, then the primary care may refer or should refer to a GI specialist or a hepatologist. If one of these tests has indeterminate result, then another testing should be performed, such as transient elastography, and that's shown to have fibrosis, such as F2 and above, then the patient should be referred to GI and hepatologist. And if it's low, the patient should be kept with the primary care for lifestyle modification. Moving to a very important topic, which is the requirement for liver biopsy, especially before treatment. And the question is, are there any tests that can predict or that can help us to enter therapies without the need for liver biopsy. As I mentioned, the current AASLD guidelines recommend liver biopsy to find NASH patients. But things have changed. And now even phase 3 trials, they enter NASH patients, but they require that these patients in general to be F2 and above. And the reason why for the F2s, we talked about it earlier in this webinar. So people started being interested in this phenomena, so they started looking at, so researchers started looking into how they can find patients with steatohepatitis, defined as NAS4 and above in clinical trials, and F2 patients. So this is an example in a study. The NIS4 score came from the Golden trial, that including these biomarkers, and again they looked at NAS4 and F2 and above patients. And they included multiple cohorts, and the area under the curve to define patients with NAS4 and F2 and above was 0.81 and 0.81 in various cohorts. Very important step to define patients who are entering into the clinical trials and likely be the patients that they're going to be treated in the future. This is an exciting score called the FAST score that uses FibroScan. And it uses multiple components of the FibroScan, including the CAP score and the stiffness, KPA, and it adds to it to the AST. This has been presented in various meetings and included various cohorts. And it uses the same concept. Here they're looking for patients that they're now entering phase 3 clinical trials. And again, the entry criteria is NAS4 and above and F2 and above. And look at the various cohort, and I'll take you to the bottom orange column where you look at the area under the curve. Very high area in the curve, maybe better than the previous score. And in the US cohort was up to 0.91. The French cohort was 0.93, and the pooled analysis showed 0.88. Even the FAST score performed better than the FIB-4 and NAFLD fibrosis score in these cohort. And here it shows you all the way from 0.82 to 0.93 in the French cohort, 0.91 in the US cohort, much higher than the FIB-4 and NAFLD fibrosis score. So these kind of tests started looking into patients that they are the fibrotic NASH that they need treatments. Another important study that was just presented in EASL from Gilead, and what they did, they took a FibroScan of 14 and above, and they added the advanced fibrosis in multiple non-invasive testing. So they used the NAFLD fibrosis score, they used the FIB-4, and used the ELF score. And the ELF score of 9.8 and FibroScan KPA more than 14 demonstrated more than 80% positive predictive value to identify advanced fibrosis NASH, which are likely the NASH, or the NASH patients are at most need to start NASH treatments. This was done in the setting of the ATLAS studies that include combination therapy that will come, the results will come in the future. So with all these tests, we have hope that non-invasive testing will be used in the future to identify patients for entry, for trials, and even to start treatments. Now, if they are starting treatment based on these non-invasive testing, and the question is, can we use that invasive testing to determine response? And in a recent paper that we published, we identified gaps on that. So the current phase 3 trials still require biopsy, which is the right thing to do because that's what most studies done. However, the question is, if the payers will be okay using the biopsy in such a large number of patients in the US and around the world to start treatment, and if they do to start treatment, many of us will be surprised if they will require a subsequent liver biopsy, especially this is a chronic disease that will require long-term follow-up, and doing multiple biopsies might be an issue. So it will become logical or plausible to use non-invasive testing. However, the question is which one? Luckily, the phase 3 studies, now they have non-invasive testing to test that. For instance, the Regenerate study that showed positive results, they had blood collection, so the hope is that will be tested in that study to see which one the non-invasive testing correlated with response. So in addition to treatment response, we also need something to decide on modifying treatment. For instance, in diabetes, let's say patient is already on metformin, and the hemoglobin A1C dropped from 10 to 9. You have hemoglobin A1C deciding that it's dropping from 10 to 9. And 9 is not enough. And at that point, many physicians add another agent. It will be nice to have something like this in NASH, to see that drop from 10 to 9, and that you need another agent to add in NASH so you can have maximizing the effect of NASH treatment. This is that Dr. Alcori and I, we wrote, and it just came out in Hepatology Communication. So based on the Gilead study that was just presented at EASL, we used the ELF and the VCTE, define fibrotic NASH patients. And we said once those are identified, they enter treatment. So on the left in green, after 1 year, if the ELF and VCTE are improved, patient continue treatment. On the right in red, if the patients are not improved, they stop treatment. And in orange, if they disagree with each other, you may consider liver biopsy. And since that publication came out, so I modified that based on the duration of the Regenerate study. And here I say non-invasive testing, which will come out for the analysis of the Regenerate study. And I say the non-invasive testing will determine which patient will require treatment, and then you enter 18 months of treatment of fibrotic NASH patients, and then after 18 months you repeat non-invasive testing, and then you look at the response. And the response will be determined based on the analysis. Let's say ELF and VCTE, or whatever the analysis come out with. And if you have a response, you continue the treatment for another 18 months and you repeat the analysis. If you have no response, and let's say initially you have partial response, you may add another treatment, especially when they come out. If you have no response, you might switch to another treatment and you repeat the non-invasive testing after 18 months. The last challenge we will face in the future, which is probably going to be a good challenge that we'll face, which is the approval of hopefully many medications, that we will have multiple medications to choose from, and we have to pick one of these medications. And these medications have various mechanisms of actions, and this is on the current pipeline of the medications that looks like this. So we have currently the thyroid hormone receptors, GLP-1s, FGFs, the fat synthesis inhibitors, PPARs, FXRs, antifibrotics as the big categories, and there are many others that are being manufactured or studied in various capacities. Again, it's a good problem to have. They have different mechanism of actions. So one approach is to look what's their side effects and look what the patient has, and base your decision based on that. Also, you can look at the target engagement, the mechanism of action at the target engagement, and base it on it. So for instance, with FXR, you can look at the C4 levels, which is their target engagement, and see if it's elevated in that patient and monitor it over time. But maybe you want to add that also to the non-invasive testing and monitor both. I know this is a little bit complicated, so let me show you what I'm proposing. So this is not the invasive testing, you do them. In addition to the previous thought I gave you, you look at the targeted engagement here and you measure it too. Again, here you have multiple medications, so you measure the targeted engagement of a certain drug. And let's say it's C4 for FXR. And then the patient proven to have fibrotic NASH, and you measure the targeted engagement, they enter treatment based on the target engagement and the NIT. You treat them for 18 months, and then you assess response and the target engagement. And as I said, we will see the analysis of response in the near future. If you have response and change in the target engagement, you continue treatment for another period and you reassess. If you don't have response and change in the target engagement, it could be partial, so you add another medication, or it could be no response at all. You might want to consider switching. So the field might get really interesting with multiple drugs and multiple mechanisms, and we're really looking forward to that day that we have to consider all these options for our beloved patients. This is my conclusion slide. I have shown you today that we made a significant progress in non-invasive testing in NASH. We do have new accurate non-invasive testings. I also showed you now that non-invasive testing predict outcomes. There are also longitudinal studies coming to show that non-invasive testings correlate with fibrosis progression. Also, now that phase 3 studies enter patients with steatohepatitis with NAS4 and above and F2 and above, we have new scores that can do that they are non-invasive scores, such as the FAST score, which is very exciting and new and has high accuracy. In the future, we will likely need a combination of biomarkers and combination of therapies, which makes this field very interesting. And the next step in the non-invasive testing will be likely to look at the longitudinal improvement of non-invasive testing along with the improvement with NASH treatments. With that, I would like to thank the CLDF and EchoSense of sponsoring this talk, and thank you very much, and I'll take questions.
Thank you, Dr. Noureddin, for that informative presentation. We have been monitoring the participant questions during the presentation, and we will now read them to Dr. Noureddin for his response. Please remember, participants can continue to pose questions in the question and answer pane on their computer, and we will put that into the queue. I would now like to introduce my associate, Lita Kota, Clinical Research Associate at EchoSense North America. Lolita will now read the questions to Dr. Noureddin. Lolita.
Thank you, Jerry. We have our first question. At the recent EASL conference, the Bercier team presented accuracy data on the FAST test. Please describe the FAST test and your impressions of its future applicability in the fibrotic NASH treatment era.
Thank you, Lolita. This is a very important question, and I had a couple of slides on the FAST score, and actually this is evolving score, and as you said, there was a presentation in EASL from the French colleagues, and actually the first presentation was in the AFLD by Dr. Newsom's group, and there was another presentation in the TAG NASH meeting. And the FAST score is basically a score that takes in consideration multiple components of the FibroScan. So it takes the CAP score, it takes the stiffness, the KPA, and AST. And there is a formula that will become public, I think, around June and July. And what they look for are patients with NAS score of 4 and above and F2 and above. And as you know, those patients are currently the patients that they enter phase 3 clinical trials or some of the phase 2. So those are likely the patients that they will be on treatments in the future or will be approved by the FDA to receive treatments. So this is one of the most exciting scores that are around nowadays. The formula will probably, I don't know if it will be available on an app or something. I would expect so, but this is what the FAST score is about. I showed you the accuracy. It's in the US cohort was 0.91, and the French cohort was the area under the curve was 0.93, and in different parts of the world varied between 0.88 and 0.93, and the pooled analysis was 0.88. So this is something to watch for in the future.
Okay, thank you. Next question. In your recent review article in Hepatology Communications, you point out the need to identify asymptomatic patients with fibrotic NASH earlier in the disease process. Based on current evidence, what NIT provides the best combination of accuracy and cost effectiveness in this role?
Another very important question. I think the cost-effective analysis should be done. We're working on something. Other groups are working on it, and actually, this is a question that I think I will divide it into which practice are you looking into? Is it primary care practice? Is it GI practice? This is gonna come in the future. I think it will be combination of tests, maybe NAFLD fibrosis score FIB4 or a fibroscan. So I think we need more analysis, and I don't want to predict that right now.
Okay, thank you. Our next question. Slide 7 shows that 22 to 24% of patients progress directly from NAFLD to advanced fibrosis in about 14 years without going through the stage of NASH. Could you speak to the drivers behind this progression?
So the patients, the simple steatosis going to fibrosis has been shown in a few publications. This is a story that's the question, right? Simple steatosis going to fibrosis and cirrhosis.
Yes.
Yes.
Yeah. So this publication in particular from England, Quintin Enstey published these data. It was a small cohort that looked at the simple steatosis going directly into advanced fibrosis and cirrhosis. That was a small cohort. The rate of progression from simple steatosis to advanced fibrosis is way less from simple steatosis to NASH and NASH to cirrhosis. I think we need more data on that. It's a phenomenon that exists out there. Maybe that these cohort we missed the NASH while we're doing the biopsy because that was paired biopsy results. But it is a phenomenon that exists there, and I think we need more studies.
Okay, great. Thank you. Our next question. Patients consistently ask how long they should expect to need to continue treatment for NASH. Do we expect patients with stage 2 to 3 fibrosis will require treatment for several years to decrease their fibrosis to stage 1 or 0? Will some patients require lifelong treatment?
Now, this is the crystal ball. That's what we're talking about. This is all prediction, and we all want to answer that question. We did not address that, which in that paper. The paper was all prediction. So let me try to answer that based on prediction, and it's provocative, and many people here might agree and disagree, and we need more data in the future. But let me base my answer a little bit based on data. So we know from the data that F2 and above correlates with mortality. So, and that's why we're entering people into treatment if they have F2 and above. So to me, if I have a patient that needs treatment, and let's say they are F3, I want to take them at least down to F1. So if they're F3, I want to take them down to F2 and then F1. Ideally, you want to take out the fibrosis down to F0. Now we have another group saying, which I probably support them, you want to actually also resolve NASH, because NASH is the driver for fibrosis. So if you get rid of the NASH and the fibrosis, you're getting rid of the driver, which is the steatohepatitis and the fibrosis together. So the ideal case scenario is you bring down the fibrosis to 0 and the NASH. But I think more research is needed. The payers is going to play a role. The FDA is going to say what is required, and this is going to be proven in the future.
Okay, thank you. Our next question. It is likely that over the next few years, we will have more than one drug approved for the treatment of NASH, leaving it up to the clinician to determine which one to choose. Do you think the choice of NIT strategy within a particular phase 3 trial today influence which drug a clinician goes with first in the future?
And repeating that?
Yep. So do you think the choice of NIT strategy within a particular phase 3 trial today influence which drug a clinician goes with first in the future?
I don't think so. I honestly believe that that's going to be proven in the future. The NITs, I believe, in the future within the clinical trials, they probably fall within the same bulk, and the response to treatment will probably we have like 4 to 5 NITs that they will look similar in terms of response to treatment and modifying treatment, and those are the 4 to 5 that we're going to end up with, maybe top 2 that we're going to use to start treatment and monitor treatment response.
Okay, thank you. And this will likely be our last question. You mentioned in the beginning that the prevalence of NAFLD varies in different parts of the world based on metabolic profiles. Metabolic syndrome is also first in the decision tree of determining whether a patient has NAFLD or advanced fibrosis. What are the components that encompass metabolic syndrome, and how can it be effectively used to diagnose in the initial screening stages?
So the metabolic syndrome actually, let me comment on the different parts of the world and the metabolic syndrome. The metabolic syndrome definition, there are multiple organizations that define metabolic syndromes. So you have the glucose level, the waist circumference, HDL, and LDL. So I will defer you to the papers that they have different cutoffs for each one of them, but those are in general the major components. Speaking about different part of the world, it's a little bit more complex than the metabolic syndrome component. You also have the genetics part. So for instance, in South America, we all know that the Hispanics are more prone to non-alcoholic fatty liver disease. We have talked about genetic component of PNPL3. Also, microbiota is a big factor, and that needs to be more studied in various parts of the world. Diet is not very well studied, and the Middle East diet, and they have high prevalence of non-alcoholic fatty liver disease, is different from other. The South America diet is different. So all these factors need to be taken in consideration. So it's multifactorial in different parts of the world that lead to different metabolic profile in these people.
Thank you, Dr. Noureddin. That was all very valuable information. This was our second webinar in a 4-part NASH series that is brought to you by the CLDF and sponsored by Ecosens North America. I urge all participants to complete the registration and attend the third webinar, which will occur on May 22nd, featuring Dr. Stephen Harrison, and Dr. Harrison will speak about the NASH drug pipeline. I wish